Okay, my name is Javier Fleites. I'm a PhD student, and this is going to be my recording for Professor Levilabo PD3 examination. We're going to be using Felipe Rossetti as a patient today. We're thanking for it. And this is what I'm going to be writing on. I'm going to show there's nothing here. It's all clear. I'm going to use it to organize my thoughts. And this is the area that we're going to be working on. Okay, I'm gonna make sure it's still recording. We're having some technical difficulties here. Okay, we're gonna start right on the minute, okay? I'm gonna use my first 2 minutes probably to write down my information, get ready here, organize my examination. We'll start in now. Okay, and we're starting now. Well, we're already counting the time, so let me complete. Okay. Hello, my name is Javier Fleites. I'm a PhD student, and I'm gonna be washing my hands, and I'm gonna be right back to help you. Okay, you're busy today. Okay, remove myself, wash my hands, come back. Okay, let's start by collecting some data from you, please. Let me get some of your bio. What's your name?
Johnny Payne,
What is your age?
78,
Date of birth?
1941,
Okay, what's your occupation?
retired Army General,
My marital status?
widower.
You identify yourself as a male.
Yes.
Okay, good. Okay, what brings you in the office today, Mr. Payne?
I have a really bad belly pain.
And when did it start?
It started 2 days ago.
And what were you doing when it started?
I was sleeping. The pain woke me up.
Have you had something like this before?
No, never like this.
Has the pain changed since it started?
It has been getting worse every day.
Okay, can you point me where it's located, where the pain is located, please? Okay, left lower quadrant. Okay, can you describe the pain when it's in first? Let me see. If the pain constant, is it cyclic?
It's constant now.
Okay, can you describe it for me?
It's sharp and intense.
Does it radiate anywhere?
No.
Any aggravating factor, something that makes it worse?
Walking and touching the area.
Okay, anything that relieves or makes it better?
If I don't move,
Okay, any other associated symptoms with the pain?
yes, I have nausea, vomiting, and fever.
In a scale of 1 to 10, how would you grade the pain?
It's a 1 and a 9. It's really bad.
Okay, thank you for that information. What can you tell me about your diet, please?
I eat 3 meals a day, lots of grains and nuts.
Do you exercise regularly?
I walk every day.
Do you use any drugs?
No,
Any tobacco use?
no,
Alcohol?
no.
Any caffeine use?
Yes, 1 cup in the morning.
Okay, and are you sexually active?
Not since my wife died.
Okay, about your any medical condition in your childhood or now that I should know about?
No, I have been healthy until now.
Okay, any history of hospitalization? You've been hospitalized before?
No,
Surgeries?
no,
Any allergies to any medication or
No.
any substance? Are you currently on any medication?
no,
Okay, what about your family? Is any medical condition that runs in your family we should know about?
none.
Okay. Do you have any fever today, Mr. Payne?
Yes, I think so.
Do you have any chills?
No,
Do you feel tired?
no.
What about vomiting? Do you have any vomiting?
One time, right when the pain started.
Is there any blood in the vomit? Was there any blood in the vomit when you
No
vomited?
blood.
What about nausea?
Yes, all the time.
What about any loose stools or constipation?
Yes, I had some loose stools.
Do you notice if your stools are tarry, dark look, or blood on it?
No,
Thank you much. Okay, you told me you're not sexually active.
no. Since my birthday.
Since your wife died. Okay, have you noticed any increase in the frequency?
No,
Any increase in the urgency? Any urgency that you noticed to go to the bathroom? Okay, okay. Now we're ready to get to start your examination, Mr. Payne. I'm gonna give you this drape. I'm gonna have you dress it properly, and I'm gonna ask you for your permission to proceed with your examination.
yes, you can.
Okay. For the examination, we're gonna start with the vitals. We're not gonna start with the blood pressure first. We normally do blood pressure sitting and supine when the patient has been rested at least for 5 minutes. It says to the first, we're gonna give the values. The blood pressure is 200 by 105, which is a little high. It's very high. Also, we're gonna get the temperature on the patient. Temperature is 102.9 Fahrenheit. He has fever. We're gonna check the pulse. Bilaterally, we're going to be checking for symmetry. The pulse is 102 beats per minute. So respiration, what we do the pulse, rise and falls 22 breath per minute. So accelerated both of them. After the vitals, we also here in this part we do the BMI. We get the weight, we get the height, and we do kilograms over the height in meters squared. After the vitals, we're going to start with general impression of the patient. The patient is well nourished, well groomed. He's alert and responsive. He's in distress due to pain. The skin, we're going to do inspection of the on the skin, and we notice that we're going to be looking at color, hair distribution, lesions, rashes. The skin is normal color, no pallor, no cyanosis. We're going to palpate for temperature. Moisture, the skin is dry, it's warm, it's dry, and there is some breast turgor on it. We're going to be observing the nails for clubbings, pallor or cyanosis, and there is no pallor, no cyanosis, no clubbing. The capillary refill is normal, less than 2 seconds. Respiratory, we're going to be doing checking the lung field. We're going to auscultate posteriorly and anteriorly. We're going to start the apex. We're going to do it bilaterally. And we're going to come down unilaterally so we can compare the sounds from both lungs. And auscultation posteriorly and anteriorly. It's all lung fields are clear to auscultation. Cardiac, we're going to do sitting and supine also. We're going to do aortic second intercostal right. Pulmonic second intercostal left, tricuspid fourth intercostal on the left sternal border, and mitral we're going to do in the fifth intercostal midclavicular line. We notice regular rate of rhythm accelerated with SM1 and S2 present, no associated murmurs. After cardiac, we're going to do the abdomen. And for the abdomen, we're going to have the patient laying supine. Laying supine here, we're going to have the patient flex the knees, here, arms resting on the sides, and we're going to uncover the 4 quadrants of the abdomen, so we can examine them. Okay, and here we're going to start with inspection. The 4 quadrants, we're looking for lesions, masses, bulges, any pulsatile masses or scars. There's none of those upon inspection. Then we're going to do inspection, auscultation. Auscultation, we're going to follow the pattern. We're going to leave the left lower quadrant for last since that's the affected one. We're going to start right upper, right lower, left upper, left lower. And auscultation. There is a decreased bowel sounds on the left left lower quadrant. After auscultation, we're going to do light palpation. For now, we're going to be examining looking at the patient face for grimace, and we're going to ask him for pain. Do you have any pain here, Mr. Pain?
No.
What about down here?
No.
Any pain here?
No.
What about here?
Yes.
Okay, and there is some tenderness in the left lower quadrant. Now we're going to do deep palpation. We're going to follow the same pattern. Any pain here?
No.
Okay.
No.
Any pain here? Can you breathe?
No.
Any pain here?
No.
Any pain here?
Yes.
Okay, and there is pain in the left lower quadrant upon the deep palpation, and also palpated a small mass in the left lower quadrant. After deep palpation, we're going to do palpation of the visceral organs. We're going to check for the kidneys bilaterally. Take a breath. Deep breath. We can go in. Okay, kidneys are not palpable bilaterally. Now we're going to do rebound tenderness in the four quadrants again. We keep on looking at the patient and asking for any pain. And we're going to be checking out for rebound tenderness. Any pain?
No. No. Yes.
Okay. Rebound tenderness. There is no rebound tenderness. No rebound tenderness. Now we're going to do percussion, same order. Right over upper quadrant, right lower, left upper, left lower, and there's a tympanic sound in the left lower quadrant. We're also going to do it in the bladder, but the bladder is not distended. Now we're going to check for CVA tenderness, right sponge. Okay. Any pain here?
No.
Any pain here?
No.
Okay. Thank you. There is no CVA tenderness present, and now we're going to do special maneuvers. For special maneuver, we're going to start with the psoas sign. We're going to put some pressure, some force upon above the knee and the right leg. We're going to ask the patient to try to raise the leg. Okay, can you try to raise it? Do you have any pain?
No.
Okay, the psoas is negative. We're going to do obturative, possibly flex the knee. While we do internal rotation, any pain?
No.
Okay, negative obturator. We're gonna palpate the McBurney point. Any pain here?
No.
McBurney point is negative for pain. We're gonna do the Robson from the left lower quadrant. We're gonna put some pressure and release quickly. Do you have any pain in the right lower quadrant, Mr. Pain?
Yes. No.
Okay, and there is no pain in the right lower quadrant. So Robson sign is negative. After the special maneuvers, we're going to do the digital rectal exam. It says to defer, well, we have the patient appropriately positioned, and we check, and the rectum is patent. And after the digital rectal exam, we did the fecal cord blood, which is negative for blood in the stools. And this is the end of the examination. We're thinking with this information we have collected, we're thinking about 5 differential diagnoses. We're thinking about, first of all, acute diverticulitis because of the location of the pain, because of the fever, the nausea, the intensity of the pain that woke the patient at night, the vomiting, the fever. We're also thinking about diverticulosis because the same reason, similar location in the same area, the fever, the nausea, the vomiting, the loose stools. Also thinking about constipation because loose stools that could be alternating with constipation, the age of the patient, because the abdominal pain, the small mass that we palpated in the left lower quadrant. We're also thinking about colorectal cancer because the age of the patient, 78 years old, the abdominal pain, the loose stools, the fever. We're also thinking about atypical appendicitis because the pain could be radiating to the left lower quadrant, but it presents very similar with the intensity, with the wakes up the patient at night, the fever, the pain, the nausea. It could be vomiting present too. So after those differential, we're going to order CBC. First of all, we're going to be looking for blood composition, specifically white blood cells, or any sign of infection. CMP. We're going to be looking at electrolytes, dehydrations, any sign of dehydration, or any kidney problem. We can also be looking at the CT of the abdomen. We're going to be looking at the bowels, of the abdomen, in the abdomen area. We're thinking about the FOB test for blood in the stools, and X-ray to be looking at the stools present in the bowel and see if there's any obstruction that we can identify. The result of the exams are white blood cells 12,000, which is a sign of fever, infection, the patient has infection. CMP is normal. CT of the abdomen came back positive for inflammation of the diverticulum. FOB is negative, and X-ray shows normal bowel stools, normal stools in the bowels. With all the information collected through the examination, the history taken, and the exam results, we're thinking about acute diverticulitis, and the treatment we're going to do it in the presentation of the case. So this finishes the examination. Now we're going to start. Start the presentation in the minute 17, so we can start counting from there. Okay. We're in the minute. Okay, we're gonna start. Now, our case today is about Mr. Johnny Payne, 78-year-old retired Army General, date of birth 2241, and who identifies as a male, and he's a widower. He comes to the office complaining of really bad belly pain, and that started 2 days ago while he was sleeping, and he's never had something like this before, and he feels like the pain is getting worse every day. He locates the pain in the left lower quadrant. He described the pain as constant, sharp, intense, and without radiation. Touching or walking makes it worse, resting makes it better, and he also has nausea, fever, and vomiting, and he grades the pain at 9 out of 10. His diet is rich in nuts and grains. He eats 3 times a day. He walks daily. He denies drugs, tobacco, or alcohol use, but he admits to caffeine 1 cup daily, and he's not sexually active since his wife died. Past medical history and family history are non-contributory. Upon review system, he has fever. He says he has fever. Denies chills. He's not tired. He admits to vomiting when the pain started with no blood. He's nauseous all the time. He has some loose stools with no blood either, and no tarry or dark color stools. He is not sexually active, he said, and he denies frequency or urgency increase. Vitals are blood pressure 200 over 105, temperature 102.9 Fahrenheit. He has fever, high blood pressure, pulse is 102 beats per minute high, respiratory rate 22 breaths per minute high also. The patient is well nourished, well groomed, he's responsive, he's alert, and he's in distress due to pain. His skin is normal color, no lesions, no pallor, warm and dry with some pre-Stargardt. There's no clovage, no cyanosis or pallor on the nail beds, and the capillary refill is normal, less than 2 seconds. Respiratory, all lungs fields are clear to auscultation. Cardiac has a regular but accelerated rate of rhythm. S1 and S2 are present with no associated symptoms. Abdomen upon inspection, there is no contributory. Auscultation have decreased bowel sounds in the left lower quadrant. Light and deep palpation gave us tenderness in the left lower quadrant. Deep palpation gave us a small mass in the left lower quadrant. Palpation of the vital organs are kidneys are not palpated bilaterally. There is no rebound tenderness, and percussion gave us tympanic sounds in the left lower quadrant. There is negative for the CVA tenderness, and special maneuvers are all negative. Psoas, obturator, Robson, and McBurney palpation point, all negative. The digital rectal examination, the rectum is patent, and there is no blood in the stools according to the FOB. For the diagnosis differential, we're thinking about acute diverticulitis, diverticulosis, constipation, colorectal cancer, and typical appendicitis. With the lab values that we already provided, we're thinking as a primary diagnosis that this is an acute diverticulitis, and for the treatment, we're going to admit the patient immediately, MPO, We're gonna start IV fluids right away. We're gonna start him on antibiotics, have IV. Since he admitted metronidazole and cefotoxin, we'll do it. We're gonna consult for immediate surgery on pain management, and that's it. Pain management. That's it. Thank you much.